Hi friends, this is M. Doc Guru, and today we are going to talk about management of head injury in the emergency departments. We will talk about how you should approach the patient and resuscitate accordingly. You continue your assessment and identify the extent of head injury and manage accordingly. Then consulting any specialties, the plan, and moving the patient out of the department. So, say this is Mr. X, and he is being brought in by ambulance, or maybe he walks in with the complaint of head injury. Now, the first thing is triaging such patients. So, any person with head injury, if they are bleeding, number one, or if you talk to them, assess their response, if they are alert, responding to voice, or responding to pain, or unresponsive. So, if they are anything but alert or bleeding, they should be up triaged and seen in priority, on priority. And hence, as per ATLS guidelines, you would want to assess the patient as a whole and just not focus on the head injury. So that is why you control any exsanguinating bleed, and immediately then assess their airway, breathing, circulation, do a disability check, and then expose the patient. So once you optimize their airway, breathing, and circulation, um, you come to D, and the most important things that you should assess and objectively note, including the time of assessment, is GCS, pupils, and any checking for any focal neurological deficits. So in GCS, which is the best GCS can be 15 and the worst can be 3, which is marked on by assessing the eye opening, verbal response, and motor response. As I said, the best GCS is 15, which is E4, V5, M6, person, spontaneous eye opening, talking normally, and purposeful movements. But the worst GCS of 3 meaning the person not opening eye, no verbal response, and no motor response. Now you document the GCS, and assessment is required to uh, define the severity of the head injury. So GCS of 8 or less is considered severe. Then GCS of 9 to 12 is classified as moderate, and 13 to 15 is considered as mild head injury. So once you do that, you then move on to assessing the pupils. In a normal person, pupils are equal, round, reacting to light, acronymed as Pearl. But if they are unequal, or if they are not reacting to light in context with the GCS, it should uh, raise an alarm, and you should document it. Then you would, as you're checking pupils, make a note of any eye injuries, any abnormal color, bruising, hemorrhage, or and document their eye movements if they are conscious. So uh, after you do the check the GCS, document the pupils, you check for any focal neurological deficits by assessing if there is any weakness in one half of the body or one limb of the body. To complete your disability check, you should consider any possibility of C-spine injuries. You should check their blood sugar levels, and assess if they have taken any drugs, toxins, or alcohol. And then take a sample history, which is S stands for signs and symptoms, A is for any allergies, M is current medication, most important to consider anticoagulants, past medical history of say stroke or brain surgeries, L for last time of last meal, last liquid or solid intake, and E is the events leading to the current situation, such as after the head injury, did the person become unconscious, or was and then brought by people to the hospital, or did he just fall, get up by himself, and come himself. So the events around the injury and the journey to you should be clear. So this as your part of your initial assessment and your approach. So once you do that, now you would identify for any red flags. Because if there are any red flags, you would want to see the extent of the primary brain injury, and that is something that you can um, do once you do a CT scan. But a CT scan means radiation, and there should be reason enough to do a CT scan. Not every person with a head injury will undergo a CT scan. So that is why we have taken these red flags, and we've considered the nice guidelines for this. So you see, if the GCS is less than 13 after head injury, as the ambulance crew tells that was the situation, or if it is yeah, less than 15, or if there is any drowsiness even after 2 hours, that should be a red flag. History of any post-traumatic seizures, fractures. Now, these blue dots that I've marked are basically differences in children. I'll keep on saying them as I move on. So, other factors are largely common. So, history of seizure, I said. Now, evidence of any fracture, so any depression in the skull, or if there are signs of basal skull fracture, so skull base getting fracture, so can manifest as panda's eyes, such as periorbital bruising, subconjunctival hemorrhage with no posterior border, CSF leak from nose, discharge from ears, or battle sign means bruising around the mastoid process. So are signs of basal skull fracture. And then we talked about assessing focal neurology. So if that is present, red flag. Vomiting, if more than one episode in adults and more than three in children. In children, you can also should also consider if there is a big wound, so more than 5 centimeters, is also considered a red flag. Then you consider any loss of consciousness, history of loss of consciousness, or retrograde amnesia, such that the person doesn't remember the events um, of more than 30 minutes before the injury. That should be an issue. And if this loss of consciousness or amnesia associated, if a person is more than 65 years of age, or on any anticoagulant, or if it is a dangerous mechanism, then that should trigger you doing a CT scan. Now, we talked about your initial approach and resuscitation. So that is what you need to do. You then decide whether to do a CT or not. And once the CT is done, until you've identified the injury, you still need to manage the patient. So, but moving on to the CT scan, what did you do the CT scan for? To assess the impact of the brain injury. So the brain injury, now coming to the point of brain injury, is also classified as primary and secondary brain injury. Now, primary brain injury is the injury sustained by the brain because of the initial trauma or the force of the impact, which can lead to, on the CT scan, you basically are looking for any fractures, any intracranial bleed, or any midline shifts. Intracranial bleeds appear, if they are acute in nature, will appear as hyperdense or hyper attenuated, whitish, bright on the scans, and you could pick up a subarachnoid hemorrhage or a subdural hemorrhage, and an extradural hemorrhage, based on how you if you can interpret the scan, or if you need the radiologist report to confirm that. Then uh, we the secondary brain injury is based on the physiological principles of uh, the blood supply to the brain. So the questions that the secondary brain injury can happen even after the impact, and this is something that is very important to consider. The questions that we need to ask after the head injury is the brain getting enough blood and oxygen, because that is required for the brain to survive, and is the brain getting squished or under stress. So these things you should consider. And it is very important you to prevent the extent of secondary brain injury. So once you've identified the impact and the damage, the extent or the nature of the primary brain injury, you've done a CT scan. Now, if there is any bleed, you would consult a neurosurgeon, or would think of either transferring the patient to a place where neurosurgery or a higher trauma center where the neurosurgical capacities are there. But between the patient, the head injury patient being seen by the neurosurgeons and up to that journey, you have to manage the extent of the secondary brain injury. So I said that these are the questions that you need to ask. And an important point is the Monroe Kelly doctrine, which says that the skull is a closed space. So if there is any bleeding, so that will, because a closed space means if there is bleeding, that will occupy space, so the brain will get squished, the blood vessels supplying to the brain may get squished, and the CSF flow can be occluded. So all that, so a rise in the volume of one component will lead to increased pressure on the other components, which is the rise in the intracranial pressure. Now, after any bleed, because of the bleeding, the intracranial pressure can rise. So there is a formula which says the mean arterial pressure, which is basically calculated as systolic blood pressure plus twice of diastolic blood pressure, sum total divided by 3. SBP plus 2BP by 3 is the map, and you minus ICP, and you get the cerebral perfusion pressure, which is basically how much high blood pressure the brain is there is the pressure in the arteries. So how much is the blood pressure, with how much force the heart is pumping, and how much with how much pressure the blood is coming to the brain. Now, if the ICP increases a lot, so the pressure on the blood vessels which are coming onto the brain will increase, and that can reduce the cerebral perfusion pressure. So CPP is the cerebral perfusion pressure, which is the indicator of how because this is telling you, is the brain getting blood and oxygen. So your cerebral perfusion pressure, if it drops less than 70, either because of loss in blood pressure, mean arterial pressure falls. So if a person has other injuries and his blood pressure is falling, then there can be a loss in the mean arterial pressure. Or if there is too much rise in intracranial pressure, so either of that can cause a drop in cerebral perfusion pressure, which can lead to brain ischemia and further damage. So remember this. And then you also know of the Cushing's reflex, where rise in ICP can at a point when the bleeding has pushing the brain so much that it can herniate through and because of the pressure, it can herniate, and at that point it can lead to very high blood pressure and a bradycardia. So the pressure on the brain stem can lead to all of that, which is the most at a point which is called as coning, and at that point you need to do something to reduce the intracranial pressure. So these principles, and with the questions of how do you prevent any secondary brain injury, I'm going to talk about the key principles that you need to keep in mind. So our aim is to minimize the secondary brain injury. So what you need to do is optimize the ABC. So ensure that the person has no airway concerns, their breathing is okay, and circulation maintaining by giving bloods, tranexamic acid, controlling bleed, or giving any blood products to maintain the vitals, because only then you can ensure that the brain will also get blood and oxygen, the supply is adequate. Then you have to of course think of the making patient comfortable, because that also has an effect on ICP. But as a holistic patient care, managing their pain, and if they are intubated because of any issues in the primary survey, then they should be sedated well to manage their ICP. So your aim is to maintain, the brain should continuously get adequate amount of blood and oxygen, optimizing the airway, breathing, circulation, making patient comfortable. You should avoid hypoxia and hypoxia, and also prevent hypercapnia, because hypercapnia can lead to again increase in ICP by dilating cerebral blood vessels. So these are the key things that you should avoid. So your aim is to maintain the cerebral perfusion pressure. So in secondary brain injury, you want to ensure that the cerebral perfusion pressure is maintained. So you manage the ICP. So you once you have done the other bits, managing ICP, so you can raise the head end. Um, we talked about if the signs of Cushing reflex are coming in, the blood pressure is getting too high, or the heart rate is getting low, so you need to raise the head end. You also need to consider preventing seizures, and then use of mannitol or 3% or hypertonic saline can be considered, which are measures to reduce ICP. Now, think it as maintaining an overall balance by now if the patient is you need to, if you maintain a good balance, that means the brain will be more salvageable, and the patient will get a complete care. So balance, when I say you maintain a homeostasis, so maintaining all the electrolytes, um, pH is important, maintaining normal temperature, maintaining a good volume balance, and as I said, electrolytes. So you do all of that, it will lead to better outcomes. Think of giving any tranexamic acid in acute bleed, any antibiotics if presence of any fractures or major wounds. Consider tetanus prophylaxis for the same. So this is how you would identify you would manage a patient with head injury. So while you are stabilizing, you have got a CT scan, and now you have now you would once your patient is stabilized, you've done a CT scan. Now you're thinking whether you should consider a neurosurgeon or not. So of course, if there is any major bleed or an abnormal findings on the CT, then you should consider discussing it with a specialist, a neurosurgeon, and based on what the discussion is, or how you think the appropriate thing is, you should make a plan. Now plan could be the patient goes to operation theater, or if the patient is not needing surgery, that point he could be going to ICU, or he could be going to a ward. uh, Now, usually patients with severe head injury are candidates for ICU, moderate head injury are for ward, and patients with the GCS or someone with a minor head injury are candidates who could be considered being sent home. Now, so GCS, as I said, patients with minor head injury are usually candidates where you think, can I send them home? And so when would you say as I said, if they require an immediate surgery, as discussed with neurosurgeons, goes to operation theater. GCS of less than 8 or intubated, or seizures in patient needs, or if they need extra vigilant or vigilance, they will go to ICU. Yeah, as I said, GCS of 12 or 9, between 9 to 12, would you would consider admitting for extended period of observation. So home, if there are no red flags, we talked about. So if a person with head injury just complaining of a bit of headache, feeling a bit lightheaded, and all of these things, so you once you complete your assessment and you see no red flags, okay, go home. Now if you saw that there were some red flags, you would think, let's do a CT. So if there is a normal CT after red flags, if they are alert or at their baseline, um, like if a person with dementia or if they suffer a head injury, you need to ensure that they at least come to their baseline cognition. And how do you check their safety to go home? So you would see if there is somebody like a responsible adult going home who can keep an eye on them for at least for the first 24 hours. So if these factors are met, then you think of discharging them to home. But also don't forget that the primary issue should be also considered, where why did the head injury happen? Was it after a syncope, so there could be other issues, cardiac or other issues. So the reason why did the patient have a fall should also be addressed. So once you tick mark on all of these, you can say, okay, the person goes home. And when you send them home, you should always make them alert of the red flags to return if any of those appear, more vomiting or any seizures happen. You should advise them on pain relief. So simple pain relief like paracetamol can be taken. And then tell them to keep a good level of hydration, get good sleep is important for recovery, and also ensure that there is a responsible company at home. So, with this, you would be able to manage and advise a patient with head injury. And I would like to know your thoughts of if you would like me to talk about something more in detail and specific. But this is the overall management. You would approach and assess the patient at the decision point of getting a CT or not, managing and preventing the secondary brain injury, and discharging if safe. Now, these are the responsibilities of a emergency physician when assessing a patient with head injury. So, see you later in our next video. Thank you.